started off in telemedicine with Eagle Telemedicine, and they were interested in having more infectious disease specialists, and so we began working together. And when we started, I worked mostly at some rural hospitals that they were in contract with, and I found it to be a really positive experience. It was a positive experience because I found the ability to provide care for those who were in need. And I think that really goes to the heart of why many of us are physicians or are in the care and service of taking care of patients. And so it allowed me to move past taking care of my local community to a larger and wider spectrum of the world, of the United States. And it had a real resonance for me in that I've spent a lot of time doing medical missions around the world, some other countries in South America, and I set up a teaching program for teaching physicians and residents and medical students how to provide care in resource-poor countries. And so doing those missions takes a toll, and they're filled with hardship, which is a good thing to be experiencing because people are living their lives in that hardship. But this also allows me to provide care to people who don't have access, certainly not equitable access to medical care that you would have in larger cities. And so it helps me as a physician to take care of the need to provide services to others who don't have access. So the training is that first you need to learn how the Eagle Telemedicine process works, and so there's computer processes that you need to familiarize yourself with. And then each and every hospital has their own EMR system. Some seem similar to other hospitals, but there's always differences, either small or large, and so you have to be able to navigate that EMR to be effective in providing care, because without that you can't review the chart or review studies, etc. And so the hospital also provides training, and part of their credentialing system has always been that you have to show proficiency in the EMR before you can start seeing patients, which is very appropriate. My memory is it takes around 3 months. So first there is having to obtain the license to practice in the state that you're going to be working in. And then, as with any hospital, there's a credentialing system, which is an evaluation of your education and your practice abilities. And there's an evaluation of any medical legal issues that there might be for any particular person or not, and to make sure that you're a physician who is in good standing and safe to practice. And so that whole process takes around 3 months or more, depending. We're fortunate at this point in time that most of us are familiar with computer use, and so the technology is not much more difficult than actually using your laptop computer. In fact, almost all of it is done with a laptop computer. That computer is provided by Eagle Telemedicine so that it remains HIPAA compliant. The actual technology of viewing patients is done through what I call a cart system, where there's a monitor in the hospital that we're working with that is able to be moved from room to room, and we can then have conversations and do exams with the patient with the nurse's help at that time. There's not a lot of high-tech difficulty in engaging in this process because all the background work has been done by Eagle Telemedicine already, and so it flows very simply. So the technology is rather good. There are some inherent limits. We're able to see the patient. We're able to hear their heart, lung, and abdominal sounds. We're able to look at wounds and skin processes. We're able to use it to have a conversation with the patient in a similar way that we're discussing and having a conversation now. We have some limitations. I cannot feel the patient's skin. I cannot know if something's hard or soft, but that's the beauty of having a nurse in the room with us as we're doing the telemedicine interview. In this way, they become the hands that we don't have available to personally feel, and they can point out things that we may not be able to see on the video camera. I would say that there's a transition process because it's unfamiliar, and anything new requires some ability to familiarize yourself with how to work in that new environment. And so when you're used to working directly with people and having the ability to put hands on to a patient, initially what felt very intimate doesn't feel as intimate when you're using a video camera. But that soon disappears as you become more at ease working with patients in that modality. And then you find that you're not providing less care than you were as if you were in person. The process of diagnosis really doesn't change. It still requires history and physical. It still requires a review of the EMR. It still requires collaboration with the other providers taking care of the patient. And in that regard, there's not any difference. Yeah. I don't really see it as much different than sitting with somebody and diagnosing them. There are some inherent limitations. I'm not present in the room, and my ability to get a sense of the person as I would when I'm sitting with them may not be as acute. I'm not able to touch them, and so that sense of connection may not be there. I don't think the tools we use are necessarily different in telemedicine than they are in person. We're still using the tools of history and physical exam. We're still using the tools of reviewing the EMR. We're still using the tools of collaborative interaction between ourselves and the other physicians on the team. We're still using the microbiology lab. We're still using biopsies. We're still using medications that are essentially the same throughout. So I don't think there's a deficit in treating people and diagnosing people just because we're using a telemedicine process. I'm not sure that there is a common diagnosis. There are common infectious disease diagnoses that we often see. I might be called to see somebody who is immunosuppressed either due to chemotherapy or because they're a transplant patient, or because they are HIV positive, or they may have a rheumatologic condition and are on disease-modifying medications and steroids that would make their immune system less easy to fight infection. We might be called to see somebody who has developed an infection on the heart valves called infective endocarditis. We might be called to see somebody who has a perforated gallbladder. We might be called to see somebody who has a skin and soft tissue infection that might represent cellulitis or some other process that needs to be evaluated. We might be called to see somebody who has a tick-borne infection. We might be called to see someone who has a neurologic process where they have a strong change in their mental status. We might be called to see somebody who has a post-operative infection of a joint. So all these things come under doing infectious diseases, and no matter which hospital we're at, we'll be seeing all these types of patients. The treatments that we prescribe are essentially anti-infective agents for the most part, but not limited to that. So we will use antibacterial agents, we will use antiviral agents, we will use, at this point in time, monoclonal antibodies and immunosuppressing agents. So we will use many of the same medications that other specialties use because it's appropriate for that patient and for that patient's care. And so our treatment ability is not limited to just antibiotics. And that's why infectious diseases is always grounded in internal medicine as well. We wait for the consult to come in or a request for a follow-up, or we're taking the sign out from the prior provider that's given to us for the next day and follow up on those patients. And then as calls come in through a HIPAA process, so either a HIPAA protected texting process or a personal call to our cell phone or through the service, we will then talk to the physician and evaluate what needs to be done, and then we will put things in motion to see the patient. Sometimes things go a little bit slower because it takes time to have the nurse break away from what they're doing to obtain the cart and then to be in the room with us as we're interviewing the patient and evaluating the patient with the telemedicine tools that we have. And this can happen multiple times during a shift or during the day, and that would be the usual. So I think the amount of time diagnosing a patient includes a number of factors. So it includes talking to the physician who makes the initial request to have an infectious disease consult. It includes reviewing the electronic medical record and examining the microbiology and other tests that are there, including reviewing the patient's history. It includes talking to the patient. It includes evaluating and examining the patient via the telemedicine. It can sometimes include the time it takes in order to get the cart available so that we can have that discussion with the patient, and then writing a note to document what we're thinking. And so that process is dependent upon how complicated that particular patient is, whether they're in septic shock in the intensive care unit, intubated on life support medications, whether they're post-surgery, or whether they have a simple skin and soft tissue infection that might be easier to move things along with. So, for many patients, it's their first time seeing a doctor in a monitor, at the base of their bed, And so, just like it will be for people who just start doing telemedicine, there's a bit of awkwardness in order to become familiar and comfortable. And I think we need to be sensitive to patients that this is their first experience over and over again, that they're not used to receiving medical care through a camera. And so it's important to introduce ourselves, to tell them who we are and why we're there, and how we're participating with the rest of the team in order to benefit them. First of all, I don't think it's the thing to do early on in one's career. I don't think that the experience and knowledge will be there. I've noticed over 20 years that I feel like I'm moving deeper into the practice of medicine almost on a 5-year interval. And so I think there has to be some time to mature as a physician before you're doing telemedicine. The second thing is you can use telemedicine in many ways. Some people want to use it for an extended income source. Some people want to do it because it allows them to serve others in areas that they may not get to. And other people want to do it because it creates a schedule that feels more meaningful to them in their lives. And so I think doing telemedicine is not a hierarchy that one approach is better than another approach. I think you just need to make sure that you're comfortable and confident enough and knowledgeable enough to operate independently. Even with the collaboration of others, it's not as much of a group process as walking down the hallway in a hospital and talking to other physicians on that patient's care. That's not going to exist so easily. And so it requires a reasonable amount of experience in order to participate in a way that will benefit everybody. Well, I think there would be natural concerns in that can they engage in the practice of medicine both effectively, safely, and at the level of care and standard that they're used to doing. And the answer is yes on all of those, that it's possible to safely evaluate and treat a patient with telemedicine, that the tools are there, and that the collaborating team members at the remote hospital are available. That it is safe because there are other people there to be responsive to the patient for acute issues, and we have access to their medical record and to discussions with the physicians and families and the patient. And it's effective because as I've been doing this over the last 2 years, the outcomes are very good. That people are getting better, their hospital stays are becoming shorter, and appropriate antibiotic use and effective use of infectious disease consults are working. So the answer is yes, otherwise I wouldn't continue doing it. And the reason I enjoy it has multiple aspects to it. So one large reason is I really feel good about providing care to people who don't have easy access to the care. It's not only for the patients, but it's difficult on the healthcare providers and the hospital systems not to have what they need in order to provide the care that they want to give to their local community. And so that's really rewarding. I like it as well because it allows me to set the time frames that I want to be engaged in working. And so the stress of doing medicine as a requirement to show up is more controllable, more handleable, and allows me to function in my life in an easier way.